Hypertrophic pyloric stenosis causes a functional gastric outlet obstruction as a result of hypertrophy and hyperplasia of the muscular layers of the pylorus. Typical presentation is onset of initially non-bloody, usually non-bilious vomiting at 4 to 8 weeks of age. Although vomiting may initially be infrequent, over several days it becomes more predictable, occurring at nearly every feeding. Vomiting intensity also increases until pathognomonic projectile vomiting ensues. Patients are usually not ill-looking or febrile. The baby in the early stage of the disease remains hungry and sucks vigorously after episodes of vomiting. Careful physical examination provides a definitive diagnosis for most infants with hypertrophic pyloric stenosis. The diagnosis is easily made if the presenting clinical features are typical, with projectile vomiting, visible peristalsis, and a palpable pyloric tumor. Serum electrolytes should be measured to document adequacy of fluid resuscitation and correction of electrolyte imbalances before surgical repair. The classic biochemical abnormality in hypertrophic pyloric stenosis is hypokalemic, metabolic alkalosis. The criterion standard imaging technique for diagnosing hypertrophic pyloric stenosis is ultrasonography. Muscle wall thickness, 3 mm or greater, and pyloric channel length, 14 mm or greater, are considered abnormal in infants younger than 30 days. Barium upper GI study is effective when ultrasonography is not diagnostic. Should demonstrate an elongated pylorus with antral indentation from the hypertrophied muscle. May show the double track sign when thin tracts of barium are compressed between thickened pyloric mucosa, or the shoulder sign when barium collects in the dilated pre-pyloric antrum. Hypertrophic pyloric stenosis is the most common condition requiring surgery in infancy. Correction of an associated fluid and electrolytes disturbances is vital prior to general anesthesia induction. Fluid resuscitation is based on the infant's degree of dehydration. Adequate amounts of both chloride and potassium are necessary to correct metabolic alkalosis. Urine output and serial electrolyte determinations are performed during resuscitation. Ramstedt pyloromyotomy remains the standard procedure of choice. The usual approach is via a right upper quadrant transverse incision that splits the rectus muscle and fascia. A supraumbilical curvilinear approach has gained popularity with good cosmetic results. Postoperatively, continue IV maintenance fluid until the infant is able to tolerate enteral feedings. In most instances, feedings can begin within 8 hours following surgery. Graded feedings can usually be initiated every 3 hours. Addition of an H2 receptor blocker sometimes can be beneficial.